we'll explain in a minute how you can go ahead and unmute your line during the portions of the webinar where we'll be asking questions, or we can go ahead and engage in dialogue. Before we do that, though, we want to go ahead and give you guys a little background on who the Latino Commission on AIDS is, and kind of what we do, and kind of the reason why we're going ahead and providing this webinar topic today. The Latino Commission on AIDS was founded back in 1990 to fight HIV/AIDS in at-risk communities nationwide. It was shaped by national AIDS advocate Dennis De Leon between 1994 and 2009. We do a lot of local, regional, and national services in more than 40 states, including Puerto Rico and the Virgin Islands. We have 5 core areas. So we have what's called the Hispanic Behavioral Research Center, which focuses mainly on developing research and data collection to influence the work that we do within the organization, and also at an international scope, and to provide capacity building assistance to other organizations and communities. We do HIV prevention and health promotion, so we, along with HIV testing and access to care, we also provide direct services at the local level. We do health policy and community mobilization, which is where John Hellman does a lot of his work, and the endeavor in which we're undertaking the presentation of this webinar is through the Capacity Building Assistance branch. And the Capacity Building Assistance division here at the Commission on AIDS is funded through the CDC, and we provide capacity building assistance to organizations and communities across the country. This is something that's done free of charge, and we're hosting this webinar through a capacity building assistance request that was submitted by Howard University as a means to market their upcoming international conference on stigma that's due to take place in November. And we'll be giving Dr. Rebecca Jackson Vargas at the end of the webinar a chance to speak a little bit more about the conference, just so you guys can find out some of those details about it. And like I mentioned a minute ago, the lines are currently all muted. And we did this just to eliminate some of the background noise. Oftentimes, it becomes a little distracting with all the lines are unmuted. It's difficult to kind of hear what's going on our end, and also communicating in an effective way. If at any point you'd like to go ahead and say something or bring up a question, you're more than welcome to do so by entering that information in the chat box, or you can also unmute your line. And you can unmute your line by pressing *7. And then you can mute your line again by pressing *6. So again, if there's at any point you want to unmute your line, you'll press *7, and you'll mute your line again by pressing *6. And with that said, we want to go ahead and give everyone a chance to kind of introduce yourselves. So what I'll do now is go ahead and unmute the lines on my end so that everyone can kind of hear each other. And what we want everyone to do is go ahead and give us your name and kind of your place of work or what you do, okay? So I'm unmuting the lines now.
The conference has been unmuted.
And again, my name is Tony Ochoa. I'm the Program Manager for National Latino AIDS Awareness Day here at the Latino Commission on AIDS under the Capacity Building Assistance Division branch of the Commission.
All right.
And again, if you can give us your name and your place of work, it'd be great to kind of understand who's on the line with us. So anyone can jump in and start at any time.
Yeah, my name is Kathy Winter. I'm with an organization called He Intends Victory. We're located in Irvine, California, and we do outreach worldwide with positive speakers and support of all kinds in microenterprise, internationally, et cetera. But most of our work is in the United States. We have 32 directors throughout the U.S. that work in local regions, and it's just a real privilege to be on this. Thank you so much.
Thanks, Kathy.
Hi, this is Kimberly Nix. I'm from the FXB Center, the School of Nursing at Rutgers University in Newark, New Jersey. I'm a case manager, outreach worker. I work with infected and affected people with HIV. That's it. I'm glad to be on the call. Thank you.
Wonderful. And I'm sorry, just for the sake of time, because you only do have allotted 1 hour for the webinar, you can just go ahead and give us your name and your place of work, and we should be good to go with that.
Okay, here, Dr. Vargas Jackson, Howard University.
Great. Thanks for joining us.
Kathy Toma, University of Florida Center for HIV and AIDS Research, Education, and Service.
Welcome.
Maria Lashata from George Mason University, Community Health major. Hi, this is Michelle, George Mason University.
Welcome.
Francisco Reynoso,
Hi, Francisco.
Jacobi Hospital, Bronx.
Patricia Houston, Howard University.
Cherise Ferguson, D.C. Department of Health.
Reese.
Shannon, George Mason University.
Great.
Karen, George Mason University.
Juliana, George University.
Great.
Rudy, George Mason University.
Welcome.
Medea Jones, Tulane University.
Fox here. We see Franny's a student at the George Mason University.
We also have Veronica with the USSD Mother, Child, Adolescent HIV Program, Rebecca from the Black AIDS Institute, and Anmal from George Mason University as well.
So we currently have about 40 people on the call, and as you can tell, when we don't have the line muted, it gets pretty distracting with the background noise. So we'll go ahead and mute the lines again now.
The conference has been muted.
And if at any point you want to go ahead and unmute your line like we previously mentioned, you can do so by pressing *7, and we'll be able to hear you. But the lines are all currently muted, so the only people you should be able to hear right now is us on our end. So with that said, thanks again for introducing yourselves. We're going to go ahead and get started with the meat of the topic. We kind of want to go over what we'll be covering today. So the agenda pretty much includes defining and describing stigma. We'll provide some data and information on service providers and stigma. We'll also be discussing some of the research that's been done by Nelson Vargas Diaz in Puerto Rico on stigma. And we'll end it with some information on the International Conference on Stigma, where Dr. Rebecca Vargas Jackson will be talking about that in a minute. So with that, I'm going to pass it over to John.
All right, so thank you again, everyone, for being on this webinar. First, I want to note that stigma as a topic is a very, very dense and complicated issue. So we're going to provide some baseline information that we think will be helpful for when we go talk a little bit more about some of the research that's out there. But we encourage everyone, once the webinar is complete, to to learn a little bit more and to hear what other folks are saying, because, again, it's a very, very complex topic. The stigma as a concept, for a lot of people, has been linked to Irving Goffman, who's one of the founders of sociology many, many years ago. But for our sake, we're going to use this definition just so that we're all on the same page for our conversation. So here we define stigma as an attribute or a label that sets a person apart from others and links the labeled person to undesirable characteristics. So there's a few important components to this definition that we really need to pay attention to when we're thinking about stigma. The first one is it's an attribute or a label that belongs to a person. So when we see someone, we're looking at a very particular characteristic, and that particular characteristic has some kind of an impact. So that's the first part of the definition that's really important. And the second thing is that it's undesirable. We're not stigmatizing people for good things. Stigma is solely a negative response to some attribute that you identify in someone else that makes them different from you. So I hope that makes sense, but those two aspects are really critical to understanding the definition of stigma. And here there's 6 different definitions of dimensions of stigma, for how we should understand when we're analyzing stigma. So these 6 here, I'll read them as a list and then go through each one, we have concealability, course, disruptiveness, aesthetic, origin, and danger. And these 6 terms are meant to describe those attributes that are in other people that we find undesirable. So first we have concealability. There's some definitions here, but if we think of, for example, the flu, someone who is suffering from the flu, sometimes you'll see that their nose is a little puffy, or they might look a little lighter skinned, or they just look sick. So they're not able to conceal the fact that they have the flu. So that it would be something, an attribute in this person who has the flu that we can easily identify by looking at it that they can't hide. So the second one, we'll keep using the flu as an example because everyone has the experience with the flu. For the most part, for a lot of folks, the flu is something that comes and goes with the season. So our relationship to someone with the flu might not be as impactful as someone with a missing arm, for example. A missing arm will probably be permanent. The flu is something that will last for a few days or a few weeks. But the course of time that an attribute manifests is another dimension when we're thinking about stigma. The third one is disruptiveness. I know if I'm working in an office and the person sitting next to me is sneezing the entire time, that's really, really disruptive. So that is another element to when we try to understand what is stigma. The fourth one is aesthetic. The flu is a little tricky because we can see a little symptom sometimes, like I said, with like a red nose or the skin just looks a little faded. But as another example, with the missing arm example I just mentioned, you can tell someone has a missing arm by looking at the arm that's not there, and that is another dimension to stigma. The fifth one, origin. For the flu, we kind of have this idea that it's flu season. You just kind of get it. If you're careful, you'll be fine. But if you're not, whatever. It's something that just happens. But for, we'll talk about this a little bit more further. But with HIV, for example, we have a heavily moralistic attitude towards HIV, where if you get HIV, that it's somehow your fault. So that's what we mean when we think about origin. And the last one, danger. Of course, I hate being sick with the flu, so if I see someone who's sneezing and coughing, I'm going to want to keep my distance away from them because I think their flu is going to endanger my health. So that's using the flu as an example, the description of all of these different dimensions of the undesirable attributes in another person that we can easily identify. So to stigmatize is the active process by which we put stigma onto other people. So the first one is more of what is stigma. We're now going to briefly talk about how stigma operates. And here we'll use a definition that describes to stigmatize as it's an individual is to give them, another person, a negative association or connection with the characteristic, and from this association, the individual will be constantly vulnerable to negative criticism or emotions from those around them. So this definition describes how stigma works when we're thinking about sort of society and how it operates between individuals. And there's 5 different components to how stigma operates as a mechanism to affect other people. The list here is 1, negative evaluation, 2, rejection, 3, ostracizing, 4, teasing, and 5, discrimination. I'm not going to go through all of these because I think this is, we see a lot of this through our work, especially with people living with HIV. But for example, if someone, for a lot of folks who work with people with sexually transmitted infections, if someone that you know acquires something like herpes or gonorrhea, a typical reaction in popular culture is to make fun of them because how could they get something like this? And we know that as a culture we don't like talking about sex. So we sometimes tease people if there's visible marks of an STI. We'll often make them feel ostracized, or we'll reject them outright, and so on and so forth. And for something another common theme when we think about stigma is race. And as we know, racism is something that's still very much alive and real in this country and in the world. And because of a different color of your skin or different facial features, you'll be subject to discrimination, and that's that is also an operating feature with how stigma works. So now we want to open it up to you guys to see what you all think about stigma in relationship to HIV. I'm going to read through these choices, and in the next slide, you're going to have a poll in front of you on your computer screen, and you'll have the opportunity to choose which one you think is the largest contributing factor to HIV and AIDS-related stigma. I'm going to read these options out loud because we don't have them listed fully in the next slide, but you can choose either A, HIV/AIDS is a life-threatening disease, and therefore people react to it in strong ways. B, HIV infection is associated with behaviors such as homosexuality, drug addiction, prostitution, or promiscuity that are already stigmatized in many societies. C, most people become infected with HIV through sex, which often carries moral baggage. D, there is a lot of inaccurate information about how HIV is transmitted, creating irrational behavior and misperceptions of personal risk. E, HIV infection is often thought to be the result of personal irresponsibility. Or F, religious or moral beliefs lead some people to believe that being infected with HIV is the result of moral fault, such as promiscuity or deviant sex, that deserves to be punished. So these are the 6 choices that you'll be able to choose from. And now, with the next slide, please make your choices to which you think is the largest contributing factor to HIV/AIDS-related stigma. And we'll give you a few seconds to make your choice. Okay, so thank you everyone who responded to this little poll. And as we can see here, the majority of people are choosing between 2 different ones. That HIV is associated with behaviors that are already stigmatized in many societies, or the second most chosen one is that there's a lot of inaccurate information about how HIV is transmitted, creating rational behavior and misperceptions of personal risk. So when we think about stigma and HIV, these are, for you guys, these are 2 of the most important dimensions when we're thinking about how to address stigma and how it operates in our society. So just a little bit more talking about the relationship between stigma and HIV and AIDS. Here, stigma related to AIDS has been defined as the prejudice, discounting, discrediting, and discrimination that are directed at people perceived to have AIDS. We know that there's no real way to tell by looking at someone whether they're HIV positive or they have an AIDS diagnosis. So oftentimes there are misconceptions about what that person will or won't look like, and we often react in very violent ways at the extreme, or in ostracizing or marginalizing ways at best. And persons with AIDS in our society, like you guys indicated in the poll, are often considered morally corrupt, and that they engage in immoral behaviors and that they do not respect their bodies. And because of these beliefs, people living with AIDS are often discounted or dismissed. The Latino Commission on AIDS is based in New York, and New York is sort of out as one of the many centers of the epidemic in its 30 years, and still we have folks trying to pass legislation to criminalize people who transmit HIV or AIDS or don't disclose whether they have HIV and AIDS. So this is something that is still very much alive in states that have a longer history of addressing the epidemic, but these are still very serious issues that we all face either in one-on-one interactions or our societal response to the epidemic itself. So now we're going to show a video that was developed. It's a HIV anti-stigma public service awareness campaign that was developed, and we wanted to show this and take a little bit back to the dimensions and the characteristics of stigma and see what this PSA is trying to do. Whether or not you guys like it is up to you all to decide, but we will use this as a tool to understand this a little bit more.
Hi, Mom. Oh, hi, you cute slut. You're up early. Couldn't sleep? I was up all night wondering how we raised a filthy plug out of tour like you. Are you going out? I'm not. This is my house. But I think we're going to kick you out. Okay. I think I'll go get changed.
So this PSA is, I remember when I first saw it, it's very shocking. You see, presumably, this girl's mother really say some really harsh things about what this girl is up to in her life, or isn't up to, is perceived to be up to in her life. We haven't seen her do any of these things, but her mom has a very strong opinion and is using very strong language to address, presumably, her daughter. And part of what is crucial to understanding stigma is that it's not always visible, and we can't always identify it when we're seeing it. So I think this PSA, one of the things that it tries to engage in is this idea that if we speak more openly and honestly about something, that might be a good thing, but we also might reveal a lot more about people's misperceptions and people's stigmatizing beliefs about HIV and AIDS. And if we go to the next slide, a lot of social marketing campaigns try to address stigma, and this is something I know in New York City, there are some campaigns out there that are trying to address the impact of HIV/AIDS-related stigma through creative social marketing campaigns. And we hear on the screen, you have the one on the left, which I believe was produced in Europe, where you have people having sex with insects, and the idea is that you don't know whether or not someone has something unless they tell you. And whether or not this is doing a good job of destigmatizing or re-stigmatizing people who have sexually transmitted infections or HIV and AIDS, that's up for you to decide. But it's trying to point to this idea that sometimes things aren't always what they appear to be. And then the other one on the right is something that we see a lot more often, this idea that it's promoting disclosure, promoting this idea that we need to talk about things more, we need to be more open and honest with HIV and AIDS, because you don't know, you're not able to identify what's going on just by being visible. So these two are, and the video are 3 examples of attempts to address HIV and AIDS through anti-stigma campaigns, and I'm sure that you all are aware of a lot more, but this is just to ground some of the definitions that we explained before. And now I'm going to turn it over to Tony, who's going to talk a little bit more about service providers.
Great, thank you, John. Before we move on, I'm going to go ahead and unmute all the lines and give anyone that's interested an opportunity to ask any questions or give any commentary on what we've talked about so far. So I'm going to go ahead and unmute the lines right now. And again, feel free to jump in and ask any questions or make any comments.
The conference has been unmuted.
So does anyone have any questions or comments so far? It doesn't seem like anyone does, which is perfectly fine. But again, if at any point anyone wants to make any comments or pose any questions, you may do so by entering that information in the chat box. So I'll go ahead and unmute the lines again now.
The conference has been muted.
And like John just mentioned, what I'm going to be talking about now has to do with stigma in service providers. And what we want to do now is go ahead and present some research that's been conducted across the country, just so we can kind of see how stigma has kind of manifested itself in different places across, across the world. So with that said, we kind of want to understand why stigma is important, why it's important for us to understand it and do some research behind it. Stigma perpetuated by healthcare providers especially has been found to be a barrier to care for vulnerable populations. And this is key, especially when we're talking about populations that are oftentimes at very high risk. And these populations oftentimes include HIV-infected people, people who engage in injection drug use, men who have sex with men, and in multiple clinical settings. And the reason why this is so important is because if as service providers we're perpetuating the stigma, the likelihood of someone engaging in care is greatly reduced. So that means that in a time where we have a national HIV/AIDS strategy that really tries to engage people and retain them in care, this is going to be nearly impossible if this stigma still exists within the services we provide. So it's important for us to continue to recognize how this stigma exists within our service provision so that we can go ahead and try to eliminate it and then provide an enhanced method of providing clinical services to the people that we work with directly. So why does stigma exist within a clinical setting or as service providers? Why does it exist? Oftentimes there's something called attributions for blame for the condition. And what attributions for blame is oftentimes we put the onus on the person that is going through this struggle or through this disease, through this illness, as the responsible party for their condition. An example of this that we oftentimes see is with research that's done around obesity. There's been a lot of research that's been done around obesity and kind of whether it's the person's fault for whether they're overweight or what the problem is there. And one of the research studies I want to highlight has to do with the use of language. There was a research study that was done where they engaged clients and asked them how they felt about when their doctors or service providers use certain words to describe their weight. So it was found that even in the way we talk, the language we use can be very stigmatizing when we're discussing weight. So it was found that things like weight and unhealthy weight were more desirable, while terms like unhealthy weight or overweight were rated to be more of a motivating factor to lose weight, while using words like fat, morbidly obese, or obese in general were rated very undesirable, stigmatizing, and blaming the person for their condition. So again, weight isn't always related to a person's behavior. It can be related to conditions like thyroid problems, which a person won't necessarily have control over. So it's kind of an example of how stigma exists outside of HIV/AIDS, but also has to do with the way in which we deliver services, the way we talk about, and the language we use, and the way we talk about HIV can also be very stigmatizing. Another reason why HIV stigma exists within this service provision world has to do a lot with the discomfort of certain populations that are oftentimes very highly impacted by the disease, right? So discomfort with the topic of sexuality. That's something that service providers should be pretty comfortable talking about, considering that, sexual interaction is one of the larger driving forces behind transmission, right? So if a service provider isn't comfortable talking about sex, that might be a big barrier and further stigmatizing within the context of HIV/AIDS. A lack of up-to-date knowledge when it comes to HIV and general biomedical advances, and their medical training in terms of holistic and patient-centered care. So maybe the person, depending on where their educational system was structured, the way it's kind of understood, didn't have this idea of being patient-centered, understanding a person holistically rather than just treating a condition. So oftentimes we understand that HIV transmission and HIV care has a lot to do with behavior. We need to understand the behavior and the reason why the person is engaging in the risky behavior they're engaging in that might put them at risk for HIV or further transmitting it to other people they're involved with. So these are some ways in which HIV/AIDS stigma exists within medical care settings. So kind of what I want to talk about now is what we've seen ourselves through the provision of capacity building assistance across the country and kind of the language we've heard used, and particularly in the way it was talked about with PrEP or pre-exposure prophylaxis or PEP, post-exposure prophylaxis. And it depends. We've seen that oftentimes people are having a hard time accessing PrEP and PEP because of the way they feel their doctors might react to it, or the lack of knowledge of their doctors or service providers might have around whether that person would be a viable candidate for this. So this is further stigmatizing in the sense that, maybe the doctor generally doesn't consider the person an appropriate candidate for PrEP or PEP, or might not have that knowledge behind how to provide this medication, this treatment, in an effective way to make sure this person can access appropriate prevention methods. So this is an example of kind of how we've seen internally as an agency a stigma kind of manifest itself through dialogue that we've had with different service providers across the country. What we're going to do now is I'm going to give you guys some examples of some research that's been done globally. And I'm going to start with a study that was done in Los Angeles. And the study the title of it was the effect of perceived stigma from a healthcare provider on access to care among low-income HIV-positive populations. And the study was done with 223 low-income HIV-infected individuals in LA. And it was found that 25% reported perceived stigma from a healthcare provider at baseline. That's 25%, right? That's a pretty remarkable number. More than 50% reported difficulty accessing care at baseline and follow-up, and perceived stigma was found to be associated with low access to care, both at baseline and 6-month follow-up. And baseline, again, is what we describe as the initiation of the study, so when they were first being brought into the study for the research, right? So that's what we describe as baseline. So these numbers are pretty remarkable, again, when we start talking about how this stigma might influence the way we retain people in care, especially when we're talking about very vulnerable populations, especially, like low-income individuals that are further marginalized by the fact that they're HIV positive, right? So we have a twofold marginalization that is existing there. Now I want to talk about a study that was done with in Malaysia with healthcare students. So mind you, these are people that will eventually be providing healthcare services to individuals. And it was an anonymous internet-based survey that assessed the attitudes of 1,296 medical and dental students towards HIV-infected people with injection drug use and MSM patients. So the way the study was done, it was done on a scale system, right? So the scale was on a 0 to 100, and they were asked to rate the. Here, I can describe this in a little more detail. Let me see if I can find the exact detail as it's written. The respondents noted that their attitudes towards these patient groups using a feeling thermometer, indicating their attitudes on a sliding scale from 0, which was the most negative, to 100, the most positive. So compared to the general patients, which was at about 76.5, the mean scores for HIV infected was at about 54, which is about half between, positive and negative feelings towards them. People with injection drug use was at about even lower at 37.5, and men who have sex with men was the lowest at 32.13. Patients were significantly lower and significantly different between each group comparison. So again, we start seeing that when providing services, not only important to understand that stigma exists within the context of HIV/AIDS, but also those risk behaviors that people are engaging in that might further put them at risk for HIV. So if we're not comfortable with those modes of transmission, it could further stigmatize, even though we might feel as service providers are completely comfortable with the topic of HIV/AIDS. There's still these other things and behaviors that exist that also work within the confines of HIV/AIDS that we need to be comfortable discussing. So now I'm going to talk about a study that was done in the South, and here by the South we mean the Deep South in the United States. And this study was done by using 25 in-depth qualitative interviews with local primary care providers and infectious disease specialists. Mind you, infectious disease specialists are those that specialize on, in treating HIV/AIDS. So we would expect that with working with infectious disease specialists, there would be reduced stigma, and understanding that stigma is a big component as a barrier to care. And with this said, we still found that providers didn't routinely offer HIV testing, which is key when we're trying to talk about that first component of the treatment cascade, or Gardner's cascade, when we talk about trying to identify those 20-some-odd% of people that don't know they're HIV positive. So routine testing is key to making sure that we reach people knowing their status when it comes to HIV/AIDS care. the reason this was set to have happened was financial barriers, financial disincentives to offer routine testing, misperceptions about local informed consent laws. So maybe the doctor didn't know about how providing an HIV test worked within the confines of their law locally and nationally as a federal law. Perceived stigma amongst patients, so how that patient might react if the doctor provided or offered that test. And believe that HIV testing was the responsibility of the health department, right? So these are some of the reasons why that test wasn't offered routinely by these primary care providers, and then further access to care. When we were talking about South Africa, there was a semi-structured interview with 100 healthcare providers, 10 patients, 8 focus groups with 41 patients not yet taking antiretroviral treatment. What we found through this was that providers seemed to minimize the effect of such barriers and didn't recognize the extent of patient dissatisfaction. So this study had more to do with whether the patient felt it was the provider's responsibility to overcome internal stigma, or whether it was the provider thinking that the patient was making up the stigma in their head, right? So what the study found was that the providers felt it was the client's responsibility to overcome the stigma, and it wasn't necessarily their responsibility as a provider to make sure they provide in a setting that wasn't stigmatizing. So overall, what we're seeing here with most of the research that's been done, that there's 4 main themes that influence HIV testing: adherence and access to care. And that has to do with access to insurance, patient-provider communication, quality of the services, and personal belief systems, all of which have to do with stigma, right? So all of these are influenced by stigma directly or indirectly in one way or another, and really impede the way in which we provide services and also the way in which our clients will access our services when it comes to us addressing HIV/AIDS care, right? So with that said, I know I threw a lot at you guys as far as research and numbers in the last couple of slides, but I'm going to go ahead before we move to the last section and go ahead and unmute the lines to offer you guys an opportunity to ask any questions or make any commentary that maybe you found some of this information particularly interesting, or you're not surprised, or feel free to ask any question about what we've presented so far. So I'm going to go ahead and unmute the lines again.
The conference has been unmuted.
So again, if anyone wants to pose any questions or make any commentary, feel free to do so now. The lines are currently all unmuted. Oh? Anyone can feel free to jump in now. Someone asked us to give our names. Here's the beginning. My name is Tony Ochoa, and I'm here with my colleague, John Hellman, both of the Latino Commission on AIDS.
I'm finishing college. Aaron. I have no homework.
Oh? We're hearing his background noise, so I'm going to go ahead and mute the lines and finish off with the last section of the webinar.
The conference has been muted.
So in the last section of the webinar, we're going to talk about Nelson Vargas-Diaz. And Dr. Vargas-Diaz has done an extensive amount of research. He's currently a professor over at the University of Puerto Rico in Rio Piedras. And his research interest is in the social, political, and individual level implications of social stigmatization. Vargas-Diaz's research has focused on the social stigmatization of disease, predominantly HIV/AIDS and addiction, marginalized groups like transgender individuals, and cultural practices like religion, and how this kind of all manifests itself and interact with one another. These interests are manifested through research, policy work, teaching at the graduate level, and independent consulting and community involvement. So I'm going to give you guys, because he's done an extensive amount of research around stigma, mainly focused in Puerto Rico, but I think it's still very relevant for us to kind of understand where some of his research is guided and where it's gone, just so we can kind of have an understanding of what's going on in Puerto Rico, and also how might also be existing within our own communities locally. One of the research topics he's engaged in is on the knowledge of legal rights among persons living with HIV/AIDS in Puerto Rico and the implications of stigma management. And you can see the names of the co-authors on this research under the topic here on the slide. So here, 103 participants completed a questionnaire. An interview process was conducted with 10 members of the same group. And the results showed that through qualitative results, that most recognized the rights amongst the participants in order for them to engage in sex, the right to marry, like examples like this is a point of measure, but most participants inaccurately indicated that people living with HIV/AIDS are forced by law to disclose their HIV serostatus status to both their partners and their physicians. So again, through this research, it was found that people didn't know the laws around disclosure, which further influenced the way in which the community might feel stigmatized about their HIV/AIDS status. So the conclusion, the findings suggest that there's a need to improve implementation of public policy that protects people living with HIV/AIDS who live in Puerto Rico, who may oftentimes be facing discrimination. Here in this research study, religion and HIV/AIDS stigma in Puerto Rico, and it was found to be a cultural challenge for training future physicians. So what we saw here was, with an ever-growing epidemic among Latinos, including Puerto Ricans living in the Caribbean islands, the social and structural factors that foster HIV/AIDS stigma need to be understood. In this study, it was documented that there was an association of religion with HIV/AIDS stigma in a sample of medical students in Puerto Rico. So this is medical students. And the findings suggest that the importance placed on religion and participation in religious activities is associated with HIV/AIDS stigma for this population. So we're seeing some sort of correlation that's going on between the medical students' religious beliefs and how stigma manifests itself within their belief system, right? So it's not necessarily saying that, religion is directly causing stigma, but there's some sort of association that's going on there. So the research is oftentimes allowing us to then potentially develop interventions and programs that might help us further understand this, or develop programs to help individuals kind of understand how we can address this or talk about this so that this can be eliminated, right? And the last example I'm going to give is AIDS-related stigma and social interactions, Puerto Ricans living with HIV/AIDS. And although personal and social consequences of the stigmatization have been documented, researchers regarding its impact on social interaction is scarce. So there isn't a lot of research that's been done generally about how social interactions and things like this exist and its implications on HIV/AIDS-related stigma. But here he's trying to kind of delve into this topic. The authors investigated the role of social interaction in the process of stigmatization through in-depth structured interviews and approximately 30 Puerto Ricans living with HIV/AIDS. Participants reported instances in which AIDS stigma negatively influenced social interactions with family, friends, sexual partners, coworkers, and health professionals. Some of the consequences they described were loss of social support, persecution, isolation, job loss, and problems accessing services. So finding support the need for interventions to address AIDS stigma and its consequences. So we see oftentimes a lot of our communities are very communalistic in nature and depend on some sort of social structure for support. So this further guides us in the idea that in order for us to provide services, we understand how relationships are navigating themselves and how stigma might be existing within those relationships that might negatively impact that person's access to care and the way they kind of feel about themselves and the way that stigma exists within their own lives, right? So for any of you that might be interested in further reading some of the research that Nelson Vargas-Diaz has done, I've included a link here, which is www.researchgate.net. I'm sorry, that should be profile, not provile. That's a misspelling. It's profile /Nelson_Vargas-Diaz. And you'll see a screen that looks something like what's on the slide now. And you'll be able to see some of the publications that he's done and has been co-authored on. So I welcome you guys to go ahead and access more of his research because it's very in-depth and it's very comprehensive, and I think it can really inform a lot of the work that we do within our communities and nationally. So with that said, I'm going to go ahead and ask Dr. Rebecca Vargas, Jackson Vargas to unmute your line. So, Doctor, if you can unmute your line by pressing *7.
Yes, I'm here.
Great. Do you want to go ahead and talk about the 5th International Stigma Conference?
Yes. Thank you so much for, the presenters, speakers. And I would like to extend a very important invitation to all the audience to the 5th International Stigma Conference at Howard University that will take place on November 21st, which is a Friday. And basically to let you know that you can see on the screen where you can register. But there are some things that they are not down there in the screen, and it's the quality of our speakers. And I'd like to mention that every year we have the participation of speakers from the White House and CDC, NIH, HRSA, OMH, UNAIDS, PAHO, WHO, and several community and faith-based organizations. In addition to that, we have at least 2 or 3 international speakers with the expertise on stigma, basically coming to interchange their ideas with us. Last year, we launched the Center for Human Rights in Health. During the conference, we are waiting for the approval from the Board of Directors, but Stigma Conference is one of the programs of this center. Other thing that I would like to mention to you is that the theme for this year is with the collaboration of about 60 organizations that participate with this organization of the conference. They have selected the theme as Lean on Me. Lean on Me means that when people from White House, CDC, NIH, or HRSA are coming, they need to tell us what are their programs in which people can lean on. What do they have available? In addition to that, we want to mention that when you go to whocanyoutell.org, you can register for the conference, but at the same time, you can become a conference organizer. We have organizers from different parts, not just of the U.S., but international people participating in the organization. One of the main issues that the partners, organizers, are part of is the selection of speakers. This is going to be everybody who's participating who tell us who's the best speaker in a particular area or agency. Another area that you can be helping us with is the selection of workshops. We have had workshops on women and stigma, stigma in the youth, faith-based organizations and stigma, stigma in new immigrant communities, sex, sexuality, and stigma. And the new webinars, workshops that we are to have are going to be with the suggestions that you are bringing to us. And basically, we're doing all of this because our principal investigator, Dr. Sohail Rana, is taking care of children with HIV/AIDS for many years, starting with these small children that they were abandoned about 20 years ago when we didn't have any treatment for HIV/AIDS. So the idea that stigma is the most important barrier to prevention efforts, to testing, to compliance, and the issue of medication is huge. So in the U.S., we have medication, we have programs, and access is probably available for almost everybody. And still, we have a large number of people that don't know their status, and stigma is what is preventing people from coming to testing. So we'll encourage everybody to register for the conference. And moreover, if you're working, as I heard before, in any area of HIV/AIDS care, and that this year we are incorporating mental health because we recognize that our patient population have lots to deal with as post-traumatic stress disorders linked to stigma and some other issues. So mental health is this year part of the conference. Please, after registering, send us a note in www.whocanyoutell.org so we can include your name and email as another organization working as conference organizers. And again, please, thank you so much to all of you for helping us to try to deal with stigma. It's a long path. It's going to take a lot of effort, but we know we can succeed. I hope to see everybody in the conference.
Great. Thank you so much, Dr. Vargas-Jackson. Actually, we have a couple questions, and I think one of the questions that someone just posed, you might be a great person to potentially answer this. So if you can stay on the line, give me 1 second. I want to read the question. And the question is from Veronica. And she said, a lot of the studies mentioned those medical students who reported more religious affiliation were more likely to endorse stigma behaviors toward HIV. She wants to know, are there interventions for healthcare providers to decrease HIV stigma that you might recommend? So do you know of any interventions or programs that might exist that might help healthcare providers minimize HIV stigma?
Yes and no. Do you know that for many years we have been telling people and using our taxpayers' money through USAID to study stigma overseas in African countries and Asian countries, which is pretty good. But for some reason we forgot that we have a stigma here. So there are so many interventions that never have been validated in the U.S. Actually, just last year, we validated tools that people have been using internationally to assess the stigma in providers. We know, yes, the providers stigmatize on a daily basis, but we couldn't use any tools. Nothing was validated for the U.S. So the answer is yes, we do have several interventions, and if somebody needs additional information on that, we can email you, or actually that could be one additional topic for our workshops in the conference, if that is something that you guys really would like to learn more about. Actually, the conference is broadcasted worldwide, so even if you don't want to come or you cannot be here in DC, you can participate in the conference via web.
Thank you, Dr. Vargas-Jackson. I think this is John Hellman from the Commission, and I think to add to that, the Affordable Care Act is a really, really big law, but part of what it tries to do in some respects with regards to health insurance, which Tony brought up, is one of those things that is definitely impacted by HIV/AIDS-related stigma, is to address it in a number of ways. I want to highlight two really quick because the law is really big and there's a lot of mechanisms to it. But one was the elimination of pre-existing conditions. If a health insurance companies before the law in many parts of the country could deny someone health insurance because of their HIV status or some other health condition that they had prior to signing up for insurance. So that removed a really significant barrier for people to open up people living with HIV and other people living with other chronic health conditions to gain access to care. And the second one is that the Affordable Care Act has a lot of really good protections for people to access health insurance based off of their sexual orientation and their gender identity. Tony mentioned a few times, and he mentioned in the studies as well, that there's a lot of stigma associated with people who engage in, for example, men who have sex with men, and we know that trans folks also experience a lot of stigma as well, and the Affordable Care Act has a lot of really good protections against discrimination based off of gender identity and sexual orientation. So I think the Affordable Care Act has a lot more, and that could be a whole conference series of webinars, et cetera, to get into. But that's just another example of something that is very good that happened a few years ago that will help us address some of the stigma when we're thinking about people living with HIV trying to access medical care.
Great. Thank you guys so much for that. And we have one other question. Dr. Vargas-Jackson, maybe you can answer this one as well. Kathy wants to know, are there scholarships available for HIV-positive persons?
Yes, and we need to give you the details because, you know, scholarships are depending upon funding sources. So we are still waiting for a couple of organizations that's supposed to provide funding for the scholarships. But please email us if you need scholarships so we can keep you in the list and on the loop. So as soon as we receive the funding for the scholarships, we can let you know.
Great. And your email or the the organizing body's email should be on the website?
Yes, on the website we have over whocanyoutell.org, but if you want to email me, you can do it. It's a very easy to remember email addresses are vargasjackson at howard.edu, and Vargas Jackson is just one word, VARGAS Jackson, and at howard.edu. So if you want to email me directly, please do so.
Great, wonderful. So, with that said, we're going to go ahead and end the call now. If at any point you guys want to reach out to either John or myself about requesting a capacity building assistance in any topic, you may do so. You're more than welcome to. My email address is tochoa@latinoaids. That's tochoa@latinoaids.org. And we thank you guys again for joining us. At the end of the webinar, once it closes, you will see an evaluation link. If you go ahead and click that, that's very crucial for us to understand how you felt about the topic covered, how well it addressed your needs, and that really influences the way in which we further develop our future evaluation webinars, our future webinars, and how we go ahead and deliver the services that you feel more useful. So with that said, again, thank you, and we'll end here. Have a great day, everyone.
Thank you, Tony. Thanks.
Bye.